Okay, let's do a little bit of review as per usual. So, for congenital adrenal hyperplasia, is the newborn screen really more for males or females? Males for the salt waste. Yep. Why? What's the female gonna? Why? She has virilization. Yep. So she's gonna come out. Yep. For primary adrenal insufficiency, what do you treat these children with daily? Medications. Hydrocortisone and fludrocortisone. Perfect. Why are kids with Addison's disease tan? ACTH to those melanocytes. Perfect. What's the true pediatric indication to give soy formula? Lactocemia. Perfect. In Hashimoto's, what is typically the TSH and the free T4 doing? TSH is and free T4. Okay, and then in Graves, TSH is and free T4. If you have abnormal thyroid studies in a child, what does the next step for the primary care PA get? Thyroid ultrasound. Yep. If you have projectile vomiting and a palpable olive, what are those electrolyte disturbances? Hypochloremia, hypokalemia, metabolic alkalosis. If you have valve sounds in the chest in a newborn baby, diaphragmatic hernia, yes. Sweet. You guys are so smart. Smart individuals. Okay, we're back into surgery. A couple more of these gut-related things to talk about as we continue our journey. So we had stopped at about the diaphragm level. We are taking it down to the umbilicus, however you want to say that, and a little bit back into that embryology that I love so much. So what happens is the gut, there is so much gut that it functionally leaves the umbilicus around week 6-ish. It goes out, it forms, it twists, it does all its things, and then it comes back in. So that's what it's supposed to do, and that's what it does. However, if that whole process doesn't just finish zipping up, you have a little midline defect right at the umbilicus, and that is then what allows those contents to have a little bit of protrusion after that. So they end up with this ventral hernia. Everything is covered, but it just is popping out of the belly button. So it's the imperfect closure of that umbilical ring from that embryologic process. So the process happens for every baby. The umbilical hernia does not for every baby. Typically, it's going to be about a finger's breadth, so about 1 centimeter. You can kind of feel it, and you're like, whoop, there's a little hole right there into the baby. But it can be as wide as about 5 centimeters. So again, pretty wide if you're looking at the size of a baby's abdomen and how big 5 centimeters is in relation to the umbilicus. This also should not ever hurt the baby. So they don't care that some of their contents are protruding. They do not care at all. Even if they're crying and there's more intra-abdominal pressure and it's more popped out, they don't care at all. The parents very much care. If it is a little bit wider than about 2 centimeters, this baby's body will not likely remodel itself to close it up. So if you have a really small defect, it'll be much like that heart. If you had a small VSD, the body can kind of repair and reattach if those are small holes. This is an area, if it's less than 1 centimeter, the baby's body can kind of repair that on its own. If it's bigger than 2 centimeters or so, really not able to be done like that on its own. Certainly if you're preterm, everything is worse when you're preterm. So if the defect is going to be a little bit bigger, more pronounced, less of those self-remodeling mechanisms, and can be seen, it can contain all kinds of stuff. So most of the time it's just small bowel, but you can see all kinds of stuff. So when do you actually need to worry about this? When do you care? So most of the time,
you will start seeing this as the baby has a rapid acceleration of growth. So around 6 months is when you typically see it. They'll have this period of rapid growth between 6 months and a year, and it will get significantly larger. If it is still there when you come for their 1-year visit, it's totally fine. They come for their 2-year visit, it's totally fine. As long as it's still small, as long as it's not strangulated, as long as it doesn't hurt them. They come for their 3-year well visit, it's fine. 4-year well visit, it's fine. 5-year well visit, it still hasn't closed. Okay, now it's an indication to go to surgery because they're going to need one little stitch to close that up. So that is your time. If it is strangulated, if it's painful at any point of them, if it's enlarging after it had been stable for a while, or if they are over the age of 5. That's when they end up going to surgery, PEDS surgery for that small closure. This is what it will typically look like. This baby does not care one iota. Literally does not care that it's got this hernia. The parents care. I've seen them do all kinds of things to include ACE wraps around this abdomen. I've seen them put Band-Aids over. I've seen all kinds of things, and it's very cute. It doesn't hurt anything, but it's not going to help that closure. So most of the time it's for parental anxiety. You see something like this. And you literally just teach them to reduce it. So you literally say, like, if the baby's crying, you literally just, as long as you can push it back in, and everything goes back inside, it's totally fine. Nothing to do there. But part of the other thing that can go wrong with the intestines is that same process. So that is if everything went out embryologically, did its twist, came back in, and just didn't quite finish zipping up. That's what happens. You have that umbilical hernia. But what if that process, the process where it goes out and it twists, what if that process gets messed up? Well, that process getting messed up is when you end up with a malrotation that can then lead to a volvulus. So what's going on here? So in that process, it leaves the umbilicus, and then it just doesn't do what it's supposed to do, and then it comes back in. So it didn't ever do the appropriate twisting, and so when it comes back in, it's truly malrotated. So you have the intestines situated incorrectly inside the gut. And because of that, you end up with lead points that can twist on each other. And when they twist on each other, that is what a midgut volvulus is, because it is wrapped around itself. What happens when things wrap around themselves? What happens to that blood supply? Yeah, so you have that blood supply that's cut off that's going to then lead to an ischemic area of that bowel from that. This is what it's supposed to do. The left side is your correct orientation, where everything is supposed to be like you know it and love it from anatomy. The malrotation is what you see on the right then, where instead of the cecum being on the right lower quadrant, it ends up being on the right upper quadrant. And that ends up being that perfect lead point for the rest of the intestines to wrap around itself. So what will happen is this child, one of the clinical presentations, it's in green for you to remember, it's past that ligament. So they're going to come with bilious emesis, bilious vomiting. So it is again that lime green look, so I should picture it. But it's truly like this lime green vomitus that they have. They will also have so much edema and so much pain from that volvulus twisting that they come in with an acute abdomen presentation. It's exquisitely tender, pretty taut, and these children are very uncomfortable if they come in with a mallow. You can get an x-ray. The x-ray can sometimes show a little bit of edema, a little bit of obstruction. It's pretty non-specific, not particularly helpful. Your barium enema, if you're going from the bottom, you're expecting to see it go through that large intestine. That's where you're going to see that displacement of the incorrect anatomy. So if you get something that looks like this, you're like, that is no anatomy that I know. That is nothing that I am familiar with. And that you're looking at that malrotated placement of those large intestines. If you went from the top and you did an upper GI, that volvulus then will show you that corkscrewing effect. So it is twisted upon itself. And so you can see that's what that corkscrew is looking like, where the gut itself has twisted. And then you're seeing the surrounding edema around it, which makes sense because there is no way for there to have any venous drainage. So you end up with that obstructed and edematous bowel. For most of these GI type things, all gonna be the same. You are making sure that they have an IV placement so that you can give them fluids, keep them hydrated, make sure their electrolytes are okay. You have that NG or OG tube to be able to decompress as much air out of the bowel as possible. And then surgery will go in, untwist everything, tack it in correctly onto the right sides, and then be able to keep everything intact. What they will typically do here is take out the appendix as well, because now you are more likely to have some other secondary obstruction as a child because your gut has been messed with, so your increased risk for adhesions, and then you had that mal-rotated placement of your appendix anyway. So most of the time, if you're opening up for a malro with a midgut volvulus, they're just taking the appendix as well. But what happens now if you just didn't even form your intestines correctly? So it wasn't that we spun incorrectly or didn't come back correctly. We just didn't even form things. That's really what intestinal atresia is when part of that small bowel just didn't form. So embryologically does not form. Usually we'll go with something else. So if you see anything on a board type question that has intestinal atresia, you're like, well, if some of the intestines didn't form, what else didn't form correctly? That should make you think something else is going on here. So typically, it will have some sort of malrotation. You can go with a genetic anomaly, so T21 is one of those. And it can be one of the places, because things didn't form, is it wrapped around the head of the pancreas. So we have an annular pancreas. So what other organs are involved with that? You may be seeing with cystic fibrosis. And so really, if you're seeing something like that in a question, you're looking for what else is wrong with this child. Or if you see it in the opposite direction, you see a whole bunch of different genetic things, you are thinking, did the intestines form correctly as well? So it can look like various things. You can have the connected blood supply, and there's a stenotic part. You can have a section that is missing. You can have multiple sections that are missing. So you can have all kinds of ways. There's various ways of shapes and sizes that intestinal atresia, different spots that it can occur. So it comes in all different flavors for that. This is very similar to a lot of the other gut presentations. If you cannot suck, swallow, and have everything go through the gut appropriately in utero, you end up again with polyhydramnios. So if you are missing a section of your intestines, you are going to have that as well. So fetal polyhydramnios is one of the signs. If you're looking for clues in a question, you say pregnancy was complicated by polyhydramnios. You start thinking, ooh, I potentially have something wrong with the gut here. And this could be one of those things. This one, if you start thinking, ooh, but maybe we talked about it was a TE fistula, right? They had vomiting right after feeding, like yesterday. So if we had that blind pouch of the esophagus, immediate vomiting. The subtle difference here is that it gets past the esophagus, it gets past the stomach, so then you're like, whoop, we've escaped pyloric stenosis. And so the vomiting is a little bit later, because it's by the time it gets down into the intestine. So if you're trying to differentiate, is it a TE fistula or an intestinal atresia, you're looking for, are there other things with this child, that intestinal atresia likely, and then what is the timing of the vomiting? So right away for TE fistula, as soon as something goes into that blind pouch, a little bit later after it's had a chance to go through some of the anatomy for intestinal atresia. Jaundice, the reason for that, again, is way back from block 1. You have your functional dehydration where things are not able to move through. So very similar, if you have missing part of your intestines that are going to be moving your bilirubin through that process, you're going to end up with a jaundiced baby as well. So for this, you end up with that, if it's a duodenal atresia, way back from block 1, that double bubble sign where you have air that can come from the top. You have the atretic part and then air where it's meeting in the middle, so you have these two bubbles that are not connecting. So a double bubble sign, if you see it on any kind of x-ray, you should think to yourself duodenal atresia. Duodenal atresia, pair that with trisomy 21. The labs that you would get, certainly you're going to make sure that the electrolytes are stable, that they have a baseline CBC, and then amylase lipase. Why are we getting amylase lipase? Yeah, to see if there's any of that pancreas involvement. because a lot of times that annular pancreas goes with this as well. Same exact management. IV fluids, electrolyte replacement, OG&G compression of the bowel. The difference in this one, so highlight this area, the difference in this one is because your risk of perforation is much higher. If you've had food that's made its way all the way down there, and that risk of stretching perforation is higher, you do cover these kiddos with a broad spectrum IV antibiotic to make sure that they are going to be prepped for surgery. So you start it before the surgery, the surgeon will continue it during surgery, and you will continue it after. Because the gut is being manipulated, opened up, and then put back together. Couple more rare things. So this is really in my world, to the NICU world, but they will come, these kids are doing super well, and so they're surviving and they're doing well up into teenager, adulthood, and beyond. And so if you see this on a history at any point, I want you to be aware of this and know what an omphalocele and gastroschisis are. So at the beginning of today, I talked about how everything is going to go out, twist, come back in, appropriately so. Another way that that could be messed up is if that process, even if it's going correctly, if there's some sort of wall defect, or if there's some other genetic anomaly that is causing everything to protrude through and then not fully come back in. So it doesn't come in, it doesn't stay out. We'll look at a couple of pictures of that. If it is lateral, so that the difference between these two, when you're looking at this, is it involving the umbilicus? Is it central, is it midline, or is it lateral? So central midline is always going to be your omphalocele. Some wall defect on the other lateral side is going to be your gastroschisis. So that is your differentiating factor, the two of those. So for gastroschisis, it looks like just a split open stomach. So there's some sort of wall defect, and functionally, the guts are on the outside, they never came back in. Does not involve the umbilicus, and there's a whole bunch of different hypothesized things that occurred, so that is not really what I want you to worry about, because there are several different hypotheses. Something with the wall, something with various blood supplies, something happened, and the guts are on the outside. So they are born with all of their intestines on the outside of their body. That means that in utero, those small intestines and anything else, any of those other organs, were directly exposed to that amniotic fluid. So the skin of a neonate is made to handle that amniotic fluid. The intestines are not. So they come out with kind of this sheet of a film on the outside of the intestines when they come out there. You can see intestinal atresia with this as well. And just because it's on the outside doesn't mean it actually works correctly. So this would not be something where you're like, well, I'm just going to go ahead and feed this baby and we'll just watch it go through the intestines that are on the outside of their body. That's not what you're going to do to manage this child. You basically say, whoa, we need to do something with the gut. So for now, we're going to feed them via IV, via total parental nutrition, TPN, and we are going to handle everything with the gut. So get the gut on the outside on into the inside. So this is how they're born. So if you're in the NICU and then a delivery, the rest of the baby is totally fine. You have the baby then on the outside. How do I know that this is a gastroschisis? How do I know that this one's lateral? Yeah, I can see it, right? Here's the cord, right? So it's not inside the cord. I can see the cord, so I know that this is lateral to that cord. Okay? So that's how I know that this is a gastroschisis. The problem is now, so the gut's on the outside, we don't know if it functions. The other thing that didn't form correctly now is this, I don't have an abdominal cavity that's big enough for all those guts. That didn't form. So how do I make a bigger abdominal cavity, protect the guts, and be able to kind of put them back together? So that is where some really, really cool neonatologists have worked with this, and so they've come up with a system called the silo. We'll look at here. You can see this is what you're looking at on prenatal ultrasound. So you're seeing the baby's spine, and you're seeing the gastroschisis that's stayed on out there. So you can see it in utero. A lot of times you know and you're prepared for this so that you're delivering at a tertiary care center. The omphalocele, we'll take a look as the management is somewhat similar. Now, this is directly some embryologic process that happened with that outer layer and inner middle layer, your mesoderm and ectoderm. Something happens with there, it's protruding in from the umbilicus. So that is one of the biggest things. This one is not associated with some lateral wall defect. This one goes with syndromes for the most part. So we had talked about the next one. So some sort of growth, some sort of syndrome with this one. So usually omphaloceles are a much bigger deal for that. Oh yeah, so the syndrome that I need you to think that it goes with, we didn't talk much about it, but Beckwith-Wiedemann. Remember what else goes with Beckwith-Wiedemann from this block? It's from the oncology lecture. Some type of tumor. It's an abdominal tumor. Nephroblastoma. Yep. So a Wilms tumor will go with Beckwith-Wiedemann. An omphalocele is often another part of that genetic syndrome. If you're looking at this one, this is then an omphalocele, so it's still covered, versus your gastroschisis that is no longer covered at all. For both of them, doesn't matter if it's covered or uncovered anymore. You're not going to try to pop that sac or anything. You're going to leave it alone. Surgery's going to deal with that. Same thing, you need to make sure the air is out of it, so NGOG, decompression of this, TPN for both, IV hydration for glucose in both, covering anything with a wet, sterile dressing, so you make sure that it is not losing any kind of heat as much as possible, and then your stage repair. So this is what I was talking about in the NICU, this really cool process. So they basically come up with a system where it is a fancy plastic bag called a silo that hangs then in front of, from the top of their incubator in the NICU, and it slowly over time, using gravity, drops the guts into their abdominal cavity. So over time, their gut is able to expand in size and accommodate all of the small intestines. So it takes days, weeks, months over time to do that. And so part of the job is to make sure the intestines are continually moist, continue to not be kinked, to have healthy tissue in that while the abdominal cavity is expanding. And then eventually, everything fits back in there and they have a pretty good cosmetic outcome. So both of these, they actually do really well. So if you're ever seeing an older patient, older kid, adult now, who has a really interesting umbilicus abdominal scar, they say, I have gastroschisis. They were born with their intestines on the outside of their body. This is what it looks like, the silo. So just be aware of that. The Meckles, I think you guys do talk about Meckles in surgery, if I remember correctly. So this is another one that got all confused. So you have some part of the remnant of the vitelline duct embryologically that got in the wrong spot. So you have the wrong type of tissue in the wrong spot of the gut, which would be fine, except when it's not. So most of these are completely asymptomatic. We had a little switcheroo in the tissue types, and so we have incorrect tissue down into that small or the large intestines. However, some of the time it's not okay. So as a reminder, you have areas of the gastric tissue and the pancreatic tissue that are down into the large intestine. Now remember, what does gastric tissue produce? Hydrochloric acid, right? How well is the large intestine equipped to handle large amounts of acid? Not at all. So when you have this gastric tissue making acid into the large intestine, it then follows that you're going to have an increased ulceration and bleeding risk at the site of where that is, dysfunctionally ulcerated. What does pancreatic tissue make? Yeah, pancreatic enzymes. What do those pancreatic enzymes do? Digest. How well is your large intestine equipped to digest things? It's not. What does the large intestine do? It's absorbing water, right, for the most part. You're not breaking down anything, right? So now if you had this, you're breaking down the tissue around it, and you're secreting acid. So bad combination, why you end up with this ectopic areas of bleeding in the metals. So at the beginning in PEDS, I said if you have to guess 2 in PEDS, all things 2, this is a perfect example of that. Anything to do with 2 goes with Meckel's. So about 2% of us have the 2 types of tissue, gastric and pancreatic, that by the age of 2 years will present about 2 feet from the cecum and is about 2 inches long. So guess 2, that's typically what you're going to see. The difference with this one, so when you're looking in your patient and then in real life, is it painful bleeding or painless bleeding? This should be relatively painless bleeding. The kid really doesn't care as much. You have this bright red bleeding that is relatively painless in a 2-year-old is the way to think about this. What it can lead to, though, is a painful process because now you have this point that is ulcerated and bleeding. It is edematous, it is ulcerated, and so that then can become this lead point for it telescoping into itself or twisting on itself, and that is the painful part. So nuance there, but Meckel's on its own should not be painful. It's the secondary effects of the Meckel's that end up painful to this child. So if you're looking to distinguish that between an intussusception or a midgut volvulus, you're looking for that original painless bleeding. If you're doing the Meckel's scan, super cool scan. Whoever came up with this is pretty brilliant. So it's a marker that labels gastric tissue, and that gastric tissue then, when they scan, is going to pick up anywhere in the body that has gastric tissue. Now, you are smart individuals. Where should gastric tissue be? In the stomach, yes. Where is it in kids with Meckel's? Correct, you have it in those 2 places, so you see 2 of those. Surgical excision of that area to make sure you remove that ectopic tissue is your treatment of choice. Complications being anytime you mess with the guts, you can have bleeding, perforation, obstruction. So here's what you see, that Meckel's scan. It is in the stomach. It is then, now that where the arrow is pointing is the ectopic tissue that you see in the large intestines. What is this then? What are you seeing down here? Yeah, so it tells you that it's excreted by the kidneys, right? And then the bottom is what? Yep, bladder, so it's excreted there. So that's the only reason it's not picking up that tissue, but that is then where it is excreted. So you see it in the stomach, in that Meckel's area, and then as it's going through to be processed. Moving on down to the very end. So as things migrate, so we had talked about this when we did GU, where the urethra will migrate, and if it doesn't migrate to the correct opening of the penis, you end up with an incorrect urethral placement. You can have that same process happen with the anus. So you need an exit hole for the GI system, and so that will migrate with certain factors as well to make sure it is in the correct place. If that doesn't happen correctly, you can have an aberrant hole, so it can be in the wrong spot, or it can be not there at all. So that's what really an imperforate anus is. So when it goes into the wrong spot, that can be really not good because you can have a large intestine that empties into the bladder or into the vaginal canal, and that can be clearly a huge infection risk, huge obstruction risk. Other thing that you will see is if it is just not there at all. So we got out of PEDS residency. My friend from residency, she goes over to Japan. She's ready to be on her own. Her first day on her own, first baby born in Japan. First baby comes out, flips it over, no anus, imperfect anus. So she was like, okay, well this is for reals, and we're gonna figure out how to get this child surgery, because if you have no exit hole, what can you not give this child? You cannot feed them, right? There is no way to get anything out. So this baby then becomes IV, fed, IV, hydrated, IV, keep your glucose up, surgical decompression, and GOG. That's what it will look like. There's literally no hole. If you're on exam, it's either a hole in the wrong spot or nothing there at all. A reason to check every single thing on a newborn baby. It does happen to our military population, and you potentially might be the person that's just out there delivering. All of these will then require some advanced imaging. So it's not necessarily just that the anus did not have its correct placement, but you are worried that what else is going on in that whole sacral region. So do you have a tethered cord? Is the rest of your cord correct there? What other kind of dysfunction, potentially from your anatomy, are you looking for with this physiology? The surgery will end up being a colostomy for now to make sure that everything is redirected and they have an exit while everything is being reformed, recreated surgically. So again, your job, decompress the bowel, IV fluids, monitoring their electrolytes, and making sure they have IV nutrition. Another thing that could go wrong then, and that was the very bottom of your large intestine, is not only does it have to migrate to the right spot, but the right cells need to migrate there so that you have the right function. So we might have the anus in the correct position, but we don't have the cells that actually tell it to contract and relax. So if you have a motility defect, so imperfect anus is your anatomy is incorrect. With Hirschsprung's disease, your physiology is incorrect because you do not have those cells, the ganglion cells that help for the functioning, for the physiology of this. So if you are missing that ganglionic section of the distal anus, then you do not have motility. So you have no control. Do you think that it then stays more open or more closed? Closed. Yep, so you have a closed system. When you have it closed, what happens proximal to that? It's continuing to increase, and you end up with a megacolon behind it, and then a closed stenotic section down at the distal apex. These babies, how they will present, and I think I've seen this on almost every board exam, is that they will have, they do not pass meconium in the first 24 hours. So a baby that exits the womb, once it is left the uterus, it starts a clock functionally to have its first stool within that 24-hour period. And that meconium, that thick, tarry stool, that first stool. So this baby classically presents with no meconium in those first 24 hours. So your differential then becomes two things. Something with my physiology is wrong. Is it wrong because my whole gut isn't moving very well, like cystic fibrosis? Or is it just that distal segment that's causing that small obstruction in Hirschsprung's disease? So for us, we're talking about Hirschsprung's disease within this megacolon that's proximal to that, and thus you end up with this recurrent bilious vomiting, again, because the lesion is past the ligament, and then you end up with even potentially feculent vomiting as well. This would be the only time functionally that in a pediatric patient that I can recall that is not a trauma in an older kid that you are going to be doing a DRE. So probably this is the first time this entire class that we have talked about doing a DRE for a little child. With that, I will say that it is both diagnostic and therapeutic. So you are opening up then the anal sphincter, and that then when you retract your finger, it helps relieve the obstruction, and then it also shows you that that's where the problem lies. So I will say please, for these small NICU babies, please use your pinky finger, not what you would typically use for a DRE. An X-ray is going to show that dilated proximal bowel, same for your enemas, and then eventually the surgeon will come and take a biopsy to see where exactly do the ganglionic cells stop, how much of that migration pattern is missed. So potentially when you look at this, so they'll do the biopsy to see where did they actually migrate to, because they need to cut out anything that doesn't have those ganglionic cells to be able to function. So wherever that is, they'll go up there, they will cut out anything distal to that, make it diverted into a colonoscopy where everything heals, and then eventually reconnect everything. We'll say since it is not a true rectum, true anus, then there is functionally, these kids have problems forever. So you play a constant back and forth of, the kid is constipated, the kid has diarrhea, they're constipated, they have diarrhea. So you are really titrating what medication do you think? Miralax. Yeah. You're titrating Miralax up or down every single day to make sure that this kid is able to stool correctly because they don't have that same gastrocolic reflex that everybody else has. Another entity that we see in general, so if you hear about this with NICU babies, is necrotizing enterocolitis. So that sounds pretty bad. For the rest of this, I'm going to refer to it as what we call it neck, is how it is referred to. So the neck, what happens in this is you are feeding an immature gut. So if a baby is born significantly premature, you want to use the gut because they're here amongst us, they're with us, we need to start using that gut, but you have to be very careful with it because it's still a very immature gut that is not made to be able to break down and handle all the things that we're throwing at it. And so sometimes, if this immature gut is unable to handle that, it will end up in an ischemic pattern where the gut itself is ischemic and unable to continue to process anything that it is doing. So it becomes infected, erythematous, edematous, and the gut itself starts to die off from that. The more premature you are, the more likely you are to see this process because the gut itself is immature. If you are feeding too aggressively, then you see this. If you are feeding not enough, you see this. So it's a very fine balance in the NICU between using the gut and not using it too much. So a very, very fine thing that you have to figure out. Human milk, so breast milk, is one of the things that helps reduce the incidence of this. So if you at all can use mom's milk or donor breast milk in a NICU setting, that is significantly improved over any kind of formula that you use. So the early signs then, so if anytime you have an ischemic edematous area in the gut, it makes sense that you're going to start with distension. So that gut is distending, that's going to be the first thing. They won't tolerate feeds well because clearly nothing is going through and it's very painful. And then something called gastric residuals. This is a fun part of the NICU and being a PEDS resident. So what will happen is, let's say the order is for 3 milliliters of human milk every 4 hours, right? Teeny tiny little amount that you're doing. The nurses give that over however long. And at the end of the 3 hours, the nurses will take that syringe and pull back to see what is left in the stomach. Ideally, it's been 3 hours. You should have nothing there. You should have no residual milk left in the stomach. What a residual is you're seeing how much is left. And as you have necrotizing enterocolitis, where things aren't moving forward, your residuals become more and more. So there are times then where you gave 3, you go back to do a residual, and now there's 6. So things are going backwards instead of forwards. That's a bad sign when you have that going on. Later sides then, you have more of an acute abdomen picture. So there's like an erythematous wall, you know, that bluish purplish discoloration where you can tell there's ischemic bowel in there. The babies can get very, very sick, go into DIC, go into shock, septic babies. This is a really, really bad situation. So if you have even the slightest hint that this baby's gut is not tolerating it, you absolutely stop feeding immediately and you just go to IV nutrition. The classic radiograph that you see for this is dilated loops of bowel, and then you can see air that is in the walls of this. So as it's dying, as that gut is dying, it allows slight amounts of air in through the lumen, and so you see pneumatosis intestinalis, where you see air truly in the walls of the gut. Very, very bad sign when you see that. Very dilated. Eventually, you can even see pneumoperitoneum. That air is escaping and it's going to then be trapped up in the abdominal cavity. Very differential can be anything that looks really sick as a baby. So anything we talked about from block 1. Could the baby be septic? Could the baby have this midgut malrotation with volvulus? Could this baby have any kind of perforation, an intestine perforation? Could they have anything that's causing obstruction? Absolutely. Premature and some of those signs, it is neck until proven otherwise. So again, you're stopping feedings, you're decompressing that bowel, everything that we've been doing for all of these surgical management. The biggest thing is to stop the feedings. Antibiotics are in this one as well because you're worried about that perforation and that air getting into the walls. This one is sad because the once the gut has died, you really can't get it back at all. So they end up having to go cut out segments. And so I've seen babies that have significant portions, 40 plus centimeters of gut taken out. And so they're functionally then, they live as short gut kids where that all is just missing. And so they have to absorb all of the food once they're older with just less gut. So they end up with short gut syndrome. Intussusception, intussusception, I think that one is covered in surgery as well. The lead point, maybe telescoping, or maybe you didn't go to surgery, maybe you're dying inside, all of the above. So at telescoping, you have something that is causing a lead point, and by lead point, it means that's the point that something went wrong. So Meckel's is a perfect example, that's a lead point. You can have a lymph tissue patch, a lymphoid hyperplasia. You can have any kind of other abnormal anatomy. It basically is a point where it catches the rest of it. So as the gut is doing peristalsis, it kind of is in kind of a wave to move everything through. If you have a point that it catches, now it's caught and it telescopes into each other. So that's what's happening with intussusception. The problem with that is that when it gets telescoped, ideally, it just comes apart. No big deal. If it gets stuck, now, when things are stuck, what else is stuck in there? Yeah, your blood supply, your nerves, and then what happens with that? Now you're getting more edematous, you're more obstructed, and so it can be a really bad scenario. We used to see this if you ever hear parents who say, I don't want the rotavirus immunization, that rotavirus, the old one, we don't use it anymore, the old formation of that used to be associated with intussusception. So do you remember what was unique about rotavirus? You gave it oral. What else? It's a live vaccine. Yep. So some of those things that you see with that. So this child comes in. So this is a little different than a Meckel's. So this child comes in with this potential bloody stool, but this is very painful. But it comes in these waves. So paroxysmal means they have these severe cramping where they're pulling their knees up. They're absolutely unconsolable, and then they are just absolutely spent and exhausted. Some really cool research in some of that looks at why they are just so peaceful and so exhausted in between those pain bouts. And it looks like some of the large intestine releases some endogenous opioids. So once that is released and the telescoping undoes itself, that endogenous release of opioids kind of puts them in this relaxed, super sleepy state. And then it telescopes again and they're back into that crampy cycle. That's that typical pattern that you see with this. Depending on how long it is telescoped, so if things can't move through, you could see some bilious vomiting with this. And depending on then how long, if it's even longer than that, and you have true death of that tissue, you end up having some of the sloughing of that internal mucosa off of that, and that is what that current jelly stool is it's bleeding from there, but also the mucosal tissue itself is coming out. You can see a mass in that upper, wherever it is, so they'll sometimes say there's like a sausage-like mass. I've never seen that, but it is in every textbook. So you see it palpable all over, you feel that goes with pyloric stenosis. The sausage-like mass goes with intussusception. The other thing that it will go with on exam, or if you're doing this radiologically, you're seeing the donut sign or the target sign. Those ones is because, again, you have the telescoping gut on gut that you can see. Interesting that both your treatment is diagnostic and therapeutic, so you can do a pneumatic or an air enema. You can do a contrast enema as well, but the air enema, you're basically shooting air up in there to see if you can untelescope the valve. So it's pretty successful most of the time. If not, you're worried that, number one, it didn't work, it's too clamped down, too much edema, so it won't untelescope, or it's going to do it again, or you have put so much vigorous air up there that now you're going to perforate the valve. So some risks associated with this, but the thing that is both therapeutic and diagnostic is your air enema. Guess what? If it doesn't work, your exact same management happens for here. So they get fluid resuscitation, NGOG decompression. All their electrolytes are placed exactly correctly, and they go to surgery where the surgeon undoes the telescoping to make sure that as much of the gut is saved as possible, resecting anything that is done. Again, same thing, telescoping, edematous, some has to be, yes ma'am.
If you're successful in the dramatic enema, is there any indication to do surgery anyway out of the chance that this is gonna happen again, or if you get it, it's gone?
If you get it, it's done. Yep. Unless they have a recurrent issue, so we had one kid that would come, like just had recurrent intussusception, and eventually that kid ended up having some of the gut just tacked down. But if you have a regular toddler that has intussusception, you're successful with that air enema, watch him for a couple hours, go on your way. This one was not able to be reduced, so this one went to the OR where you were seeing that telescoping valve. And this is the saddest picture. I don't know in what old textbook they let this baby sit here with this currant jelly stool and then a sausage-like mass. So very sad picture in your textbook. But that is a picture of intussusception in New Zealand. Can you okay, so for your appendicitis, this is a very quick review because this is the most similar thing as the adults. The reason that we are talking about it here, you're like, we beat appendicitis to death in surgery, but the reason is that of all the things we talked about, this is still going to be your most common surgical emergency in kids, right? So even though it looks the same, even though it presents somewhat similar, we'll talk about a few of those little differences, but we have to hit it because it is still the most common thing that you see for children. Most of the time, it's going to be in that school age child, so less common if they're younger than 5. So you really think those young elementary, early middle school kids if you're having to guess what pattern that you're typically seeing. Something is obstructing it. If the most common thing is the fecalith, the poop stone. You can also see, again, if you have that lead point of some sort of lymph hyperplasia. And then you could see even more rare a tumor that is on there. So something is going to proliferate, that bacteria increases, and eventually then you rupture. Same exact thing, nothing is different here from the adults. I will say one of the most common presenting symptoms that is slightly different for a child is the true anorexia. So most kids, even if they don't feel good, if they have other abdominal pathology, if you say, what's your favorite food? And they're like hamburgers or pizza. And they have true appendicitis, if you're like, if I brought you a pizza right now from wherever, would you eat it? Most of the time in other pathologies, they'll still say yes. For appendicitis, they're like, nope, don't want that. So true anorexia in a kid should increase your suspicion that it is appendicitis. As a reminder for your scores for this, so you still get a score if that pain started periumbilical, so the same as constipation. So you're like 99 times out of 100, this is going to be constipation, and you're constipated, and you're constipated. The true appendicitis is going to do just what you learned for the adult, migrate down into that right lower quadrant, that McBurney's point. You get a point for true anorexia, you get a point if they're nauseous or vomiting, that rebound pain anytime, a fever, and that drives me nuts because the criteria is not a fever. Just gonna leave that. Elevated temperature, just go with it. And then if you have the WBCs with that neutrophil predominance, more than 75. Again, that then increasing points if it is that true right lower quadrant tenderness and certainly a leukocytosis. So as a reminder, if you don't score, if you score less than 4, really unlikely it's that, more than 7, highly likely. The other difference that I want to point out is everything else is the same for adults. So you're still going to get your labs. With the UA, so if you're getting a UA in a urine culture and you're like, why are we doing that? In children, you'll have a sterile pyuria. So you'll see white blood cells, and you'll see no other signs of infection. So sterile pyuria is one thing that you're going to see different. The other thing for your scans, in the adult world, you are going to order CT scans because it's a day that ends in Y, right? You're just like CT scan this, CT scan that, CT scan everywhere. Everybody gets a, it's like Oprah for CT scans, like everybody gets a CT. For kids, most protocols will say let's start with the ultrasound. If we can't visualize it, then we'll go to CT. So your first test of choice on any test, on any protocol, on any hospital you have is going to be your ultrasound. Certainly your treatment is going to be the same. Move it out of the way, and antibiotics if it ruptures. And then a quick reminder, the surgical abdomen, so for all of these, if you ever have guarding, you have rigidity, the psoas sign, heel tap, rebound, obturate, any of these signs, if you see any of these on any kind of test question or in real life, your suspicion should be increased that this is a true surgical abdomen versus any kind of other GI pathology. Couple things just for studying purposes when you're studying this for next week. If you can remember which ones present at birth or not, how the feeding patterns are associated with it, if there's bilious vomiting versus non-bilious vomiting, anything that goes with polyhydramnios, and then the ages as normal. So just a few things to study. And then all of this is just for phase 2. We'll do that. If you need that in phase 2, great. And that is surgery. I know I went a little bit over, so let's take 10, and then we will do the first section of PED so that we